I will now shortly introduce my PhD thesis, Influence of the Choice of Protocols on the Accuracy of Three-Dimensional Medical Models, Surgical Guides, and Bone Replacement. Searching the PubMed page for the term 3D printing in scientific papers, in the last 30 years, we can see the exponential growth of the term usage in the last 10 years. The dominant fields of 3D printing usage are for surgical guides, medical models, and custom implant fabrication. In the field of orthopedic knee surgery, maxillofacial and cranial surgery. Virtual surgery planning workflow starts with data acquisition phase where patient MRI and CT scans are done. DICOM data is transformed to 3D models, which are then used in the second phase and transformed into the 3D printed medical model surgical guides, which are then used in the surgical procedure. Virtual surgery planning and guided surgery procedures have shown beneficiary effects on surgery throughout the scientific works. Main problems of medical 3D printing in bone reconstruction surgery are unknown defects of different radiological protocols and technologies on 3D printed medical models and surgical guides, lack of any report of long bone over critical size defect reconstruction without stem cell seeding, bone morphogenetic proteins usage, and external fixation with or without 3D printed procedures during reconstruction. And finally, despite the immense number of scientific works dealing with 3D printing in medicine, only few of them report actual 3D printed items usage in surgery. In the first research phase, we scanned one dry human mandible from the archaeological context with two different scanning technologies with CVCT and multi-slice CT scanners, using 8 different radiological scanning protocols to obtain 8 3D models of the human mandible and to 3D print these 8 3D models as the 3D printed medical models of the human mandible. We compared both the scans, 3D models, and the 3D printed medical models for linear volumetric measurements comparison. In the second phase of the research, we synthesized the elbows material for bone reconstruction procedure, checked its suitability for the procedure, did the radiography and virtual surgery planning of the defect induction and defect reconstruction on the experimental animal, 3D printed medical models and surgical guides for the bone reconstruction procedure, as well as bone reconstruction scaffold, which was then checked and characterized for the suitability for the implantation. After verifying its biocompatibility and microstructural properties, it was used for the reconstruction of over critical sized bone defect of the rabbit's ulna, which consisted of 1/4 of the total bone left. Animal was sacrificed 12 weeks after reconstruction, where the bone scaffold area and the surrounding old bone was subjected to micro-CT analysis, immunostaining, and histology analysis. In the third research phase, we used all our previous results to form virtual surgery planning and 3D printing in-house concept. We used our concept to reconstruct large bone defects of the mandible in clinical environment. We included 7 individuals in the experimental group, which was operated with the usage of virtual surgery planning, and 5 individuals were in the control group. We compared the both group for surgery time of hospitalization, surgical complications, final functional and aesthetic result, and patient satisfaction. We used adequate statistical analysis and software, and we used statistical significance level of 0.05. In the first research phase, we determined that the most precise radiological protocols for medical model of the human mandible production are CBCT standard and high resolution protocol, closely followed with the Dental 20 H60 multi-slice CT protocol, which is our recommended protocol for both donor and recipient region scanning. In the second research phase, our 3D printed bone reconstruction scaffold has shown favorable microstructural and wettability properties. The scaffold has also shown good cytocompatibility properties without cytotoxicity. Osteoblast cells attachment tests indicated good cells adhesion on the construct surface and even shown osteoinductivity size bone defect reconstruction of the rabbit's ulna. Control radiographs have shown adequate healing. Reconstructed bone area was explanted 12 weeks after reconstruction and subjected to micro-CT analysis. Micro-CT analysis has shown that there was no statistical difference between central and peripheral parts of the reconstructed defect. It has also shown that there was no statistical difference between the old bone and the new bone in the closed porosity and cortical thickness, while there was statistical difference in open and total porosity. Histomorphometric analysis did not show significant differences between central and peripheral parts of the defect, neither in a new found bone on the mineralized surface area. Immunofluorescence staining of anti-bone morphogenetic protein 2, osteocalcin, and anti-osteopontin antibodies did not show any statistical difference between the old and the new bone. Clinical implementation of virtual surgery planning did not result in statistical significance when measuring surgery duration between the experimental and the control group. Surgical complications were registered in one case in the control group, while average time of hospitalization was significantly better in the experimental group. Final functional and aesthetic result was significantly better in the experimental group, measuring both traditionally and with a novel volumetric approach. Patient satisfaction was also significantly better in the experimental group. After successful testing of our 3D printing and virtual surgery planning model in clinical environment, we advocate for further research and development as well as broader clinical implementation. Thank you for your attention.